ladies and gentlemen. Thank you very much for tuning in to the Round Round series where I will be presenting anonymized, interesting cases that I have encountered over the years. I'll start the ball rolling by presenting a case I've encountered in emergency department. And I'd like you, my listeners, to just work through the specific complaints. Think about your differentials and pause the video along the way. Tell me your differentials and tell me about your management and investigations. So let's start the ball rolling. So you were asked to see a 74-year-old lady with no past medical history aside from hypertension, for which she takes some ACE inhibitors. She it's the time that you see her is at 4 a.m. She was noticed last well at 3 a.m. God knows why she was up so late in the morning, with right-sided weakness. So what would you do next? Well, this is in sort of an emergency setting, so obviously, you'd need to take an ample history. Now, pause for a bit. What is an ample history? Have you heard of what an ample history means? Well, basically, it's sort of the key elements of the history, which you sometimes try and do if you're short of time, and consists of the mnemonic ample. So A for allergies, M for medications, P for past medical history, L for last meal or intake, and E for events leading to presentation. And obviously, the events leading to the presentation would be the most important part of the history. So upon further history gathering, you speak to, the husband's come along, so that's always helpful in any history taking, having a collateral history, especially if the patient is unable to give any history. So you find out from the husband that she's had this right-sided weakness since about 3 a.m. when she was last well, with some weakness as well. So what do you do next? Well, what is your history? Well, so far, what does the history suggest? So the sudden onset neurological deficit potentially. So you carry on to do your neurological exam. You find out that she's got right-sided neglect, right-sided weakness, and right upgoing planters. Now, that gets even more interesting, doesn't it? So what would you do next? Investigation. Well, obviously, you wouldn't want to miss, in terms of differentials, number one, any hypoglycemic event. Obviously, it would be ridiculous if one were to miss that. And yes, we do come across this sometimes. And obviously, you'd like to scan her head. What would you be looking for on a head CT? Well, obviously, the two differentials in this case is a stroke. Now, what is the definition of a stroke? Definition of a stroke is any acute cerebral event leading usually to some focal neurological deficit. And the importance there is a deficit. So if we, for example, were to compare to other neurological conditions such as migraine, which tend to present with additional features, so such as headaches or flashing lights, whereas a stroke tends to be a deficit, a weakness, for example, or slurred speech. So we scan our head, and bam, what do you see on CT? Yes. So, as many of you may have guessed, it shows a hyperdense MCA sign. And what that means is a fresh clot, basically. And that means it's even more important because, again, brain. Time is brain, just like your MI. So what do you do? Well, what if you didn't have any telestroke service? What does happen in certain areas? So first of all, you'd want, or given the severity of this stroke, you'd like to carry out a formal assessment, and that would, for example, involve performing an NIHSS score. I'll put a link below to what it involves, but basically it's NIH stroke scale or score, which takes less than, let's say, 3 minutes to do, where you ask the patient to perform certain activities, such as assessing their loss of consciousness, their gaze, their visual fields, their motor and sensory deficits and language and so forth. I'll put a link below to the full details of that. So you assess our NIHSS score, and it's 22. Given the severity of this disability, aside from potentially giving it, aside from the two options here are either giving her aspirin, so antiplatelet, 300 milligrams once daily, or given the severity of her illness, you would definitely want to consider thrombolysis if she does not have any contraindications. Now, when you're on call, it's always good to have a checklist of potential contraindications of thrombolysis in your mind. But number one would, for example, be that the patient was on warfarin with an elevated INR, 1.5 or above, for example, or if the patient had very severe uncontrolled blood pressure with a blood pressure, for example, of 200 or above. Now, I'll put a link below as to the list of all the potential contraindications. Now, moving forward, let's say the patient does not have any contraindications, and you decide, therefore, to move on and to discuss with the husband about potential thrombolysis. Now, thrombolysis involves basically giving a bolus dose, 10 milligrams of, so it involves infusing basically 90%, infusing some alteplase into the patient. Bolus dose is given over 1 to 2 minutes, and the remainder over an hour. So, following thrombolysis, and throughout thrombolysis, you'd need to carry out regular observations, including NIHSS score and blood pressure as well. Very rarely, patients do develop they do develop a swelling or angioedema of the mouth, and in that case, you would unfortunately need to stop the infusion and obviously protect the airway. Consider anaphylaxis as a potential diagnosis and treatment. following thrombolysis, you notice marked improvement of the patient in terms of her weakness. So that's really good. And you feel much, much better, especially as you're counting down to the final few hours of your night shift. Congratulations. So, what do you do after that? Well, after thrombolysis, you repeat a CT head 24 hours later, and following this, you if the head scan does not show any bleed, you commence regular aspirin, 300 milligrams once daily for 2 weeks. If there's bleed, well, unfortunately, things can either go pear-shaped or stay stable. It all depends on the severity of the bleed, and amongst other things. Well, that wraps up the first episode of Grand Rounds. If you have any comments, questions, or concerns, please feel free to leave a comment below. Your comments would be most appreciated. If there are any further suggestions, again, please feel free. And obviously, we'll be grateful if you can subscribe and share this channel to your other colleagues. Thank you very much for listening, and have a good day, everyone. Thank you so much.